चिपका जाएगा। So you remember this face? This is Christopher Reeve, superhero, Superman. He got injured with a spinal injury, got paralyzed, paraplegia. He was not able to bear weight on his lower limbs. There is no cure, only ambulation with wheelchair. So spinal injuries usually occur as a result of high energy trauma, devastating consequences on the high quality of life of a patient. It may be temporary, may be permanent disability. There's still no cure for spinal cord injuries. Loss of productivity and life. First, we have to know the relevant anatomy. There are 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. Sacral and coccygeal element fused, so there are 24 mobile segments. There is S-shaped curve. Cervical spine has natural lordosis. Then dorsal spine has kyphosis, and lower lumbar spine has lordosis again. Cervical and lumbar segments of the spine are mobile, while the mobility of the thoracic spine is restricted due to the rib cage. That is the reason most mobile segment, thoracolumbar junction, is more prone to injuries. We all know the vascularity of the spinal cord. Anterior spinal artery is predominant and it covers 2/3. 2 posterior spinal arteries, many feeder vessels, valveless veins that we know as Batson plexus. The artery of Adamequez is the largest feeder of lumbar cord. It is located on the left side, usually at the level of T9 to T11. The supply of the thoracic cord from approximately T4 to T9 is much poorer than the rest of the cord. So this is the anatomy: anterior longitudinal ligament. This is posterior longitudinal ligament. It is facet capsule joining superior facet and inferior facet. There is spinous, supraspinous ligament and interspinous ligaments. Anteriorly, there is intervertebral disc, ligamentum flavum, which covers the cord from behind. This is Dennis 3-column model of stability. Anterior column is made of anterior longitudinal ligament, anterior half of the body, and anterior half of the disc. Middle column has posterior half of the body, posterior half of the disc, and some part of the cord. And posterior portion column is made up of spinous process, interspinous ligaments, and posterior half of the canal. So this is facet orientation. This we should understand the trajectory of pedicle to put the pedicle screws under C-arm guidance. In scoliosis, this shape of the pedicles get deformed, and thus we need a CT scan for preoperative planning to put the pedicle screws in scoliotic spine. So any injury, we should have suspicion of a spinal cord injury. ATLS protocol now has airway and cervical spine stabilization in high view of suspicious spinal injuries which get missed. Any blunt injury above the clavicle, a head injury or loss of consciousness, any polytrauma patient, any patient who has fallen from height or involved in a high speed motor vehicle accident, any trivial fall in an elderly and osteoporotic patient, any pain in the neck or the back, limb weakness, sensory symptoms, that is neurological deficit, and bladder bowel affection. General examination remains the same. ATLS protocol, primary survey, airway, breathing, circulation, deformity, and exposure. Hypotension in a spinal injury patient is maybe because of hypovolemic shock or maybe because of neurogenic shock. If it is hypovolemic shock caused by blood loss and suggested by hypotension and tachycardia due to reflex sympathetic stimulation. In neurogenic shock, this occurs due to loss of sympathetic pathways in the spinal cord, leading to peripheral vasodilation causing hypotension, and cardiac depression, thus bradycardia. So there will be loss of blood pressure and bradycardia that suggest neurogenic shock. Whether in hypovolemic shock there is blood loss leading to decreased blood pressure, but tachycardia, compensatory tachycardia will be there. So the urine output will be normal in neurogenic shock, and in hypovolemic shock there will be low urine output. And the extremities will be warm in neurogenic shock, and in hypovolemic shock there will be cold extremities. So spinal cord dysfunction based on physiological rather than the structural disruption. Resolution of spinal shock when reflex arch caudal to the level of injury begins to function again, usually within 24 hours. Most common in cervical and upper thoracic injuries, almost resolves within 24 hours to 48 hours. Bulbocavernous reflex, we should know how to look for it, is the first to return. Different from neurogenic shock. Secondary survey, any abrasions, bruises, penetrating injuries, deformities, swelling, etc. should be noted. Palpation should reveal any areas of the spinal tenderness, interspinous gap or step. Patient should be moved as minimal as possible. If you have to transport the patient to CT or X-ray, the spine board should be used and cervical collar has to be applied. Log rolling, we should know. Log rolling is turning the patient as a one piece, just like a log of wood. In spinal cord injuries, we need to initiate the roll with count of 3, maintain cervical spine straight, nose aligned and umbilicus, apply cervical collar if available before log rolling. 3 assistants to roll patient, crossing arms, one at the level of the shoulders, one at the pelvis and one at the level of the knees. Turn patient toward them on the count of 3. Patient roll back on leader's count. So one has to guide and others has to follow at the same time. Neurological examination, as you all know, muscle groups, you need to check. For C5, you have to check elbow flexion, that is biceps and brachialis. C6, you have to see wrist extensor. C7, elbow extension, that is triceps. C8, finger flexions. T1, small fingers, abductor, that is abductor digiti minimi. Then comes to lower limb. L2 is hip flexors, iliopsoas. L3, knee extension, that is quadriceps. L4, ankle dorsiflexion. You look for the foot drop. L5 is EHL, long toe extension. S1 is ankle plantar flexion. So with this, we can screen which myotome is involved based on the functional outcome. This is ASIA, American Spinal Injury Association classification. ASIA grade A, B, C, D, and E. A is No motor, no sensory function is preserved in the sacral segment. And E is normal. Motor and sensory function are normal. So B, C and D is incomplete. B is sensory but not motor is preserved. C, motor function is preserved below the neurological level, and more than half of the key muscles below the neurological level have a muscle grade less than 3. So it is not useful. D is when the neurological muscle grade is more than 3, which is useful. So we have to know that complete cord injury is type A, ASIA grade A, and the normal function is ASIA grade E. Rectal evaluation, we have to look for sphincter tone, anal wink, sacral sparing if it is there, bulbocavernous reflex we have to know. If the patient is catheterized, it is checked with pulling the catheter and putting the finger in the rectum. So as the constriction occurs when you pull the catheter, that is bulbocavernous reflex positive, and its presence marks the end of spinal shock. Complete spinal cord injury, no sensation or voluntary motor function is noted. Caudal to the level of the injury is the presence of an intact bulbocavernous reflex. Prognosis for recovery is extremely poor. If it is incomplete spinal cord injury, some neurological function will be preserved caudal to the level of the injury after the return of the bulbocavernous reflex. Various patterns may be seen: anterior cord, central cord. Central cord is most common in degenerative spine, like old age patient with a trivial trauma, they develop central cord syndrome. Brown-Sequard syndrome, conus medullaris, cauda, equina, and the respective root injuries. This you have to know descending motor tracts and ascending sensory tracts. Lateral corticospinal tract is motor tract. Ventral corticospinal tract is motor tract. Dorsal column is proprioception, deep touch, vibration. Lateral spinothalamic tract for pain and temperature. Ventral spinothalamic tract for light touch. So in a anterior cord syndrome, areas involved anterior gray matter, corticospinal thalamic tract, complete motor and pain and temperature sensory loss with preservation of the proprioception and deep pressure sensation. It has poor prognosis. Anterior cervical cord syndrome. Then comes central cord syndrome. It is most common in incomplete spinal cord injuries, destruction of the central area of the spinal cord, including gray and white matter. The centrally located arm tracts in the corticospinal areas are the most severely affected, and the leg tracts are affected to a lesser extent. Generally, patients have a quadriparesis involving the upper extremity to a greater degree than the lower. Upper limbs में ज़्यादा weakness होगी, lower limbs से. Sacral sparing may be there. Prognosis is good. This is Brown-Sequard syndrome, where injury to either half of the spinal cord, usually associated with the penetrating thoracic injuries. It is characterized by motor weakness on the side of the lesion and the contralateral loss of pain and temperature sensation. Prognosis for recovery is good. This is Conoconus medullaris syndrome, injury to the sacral cord, conus and lumbar nerve roots within the spinal canal, bilateral saddle anesthesia, areflexic bladder, bowel and lower limbs. Muscle strength usually preserved. May have upper motor neuron signs. This is cauda equina syndrome, injury to lumbosacral nerve roots in the spinal canal, low back pain with radicular pain, asymmetric leg weakness and sensory loss. Being a peripheral nerve injury, possibility of recovery if not completely transected. How to manage the spinal cord injuries? Starts from the accident site care. How you lift the patient, how you transport the patient, hospital emergency care, then pharmacological measures like steroids has to be given or not. Accident site care, you need to protect the cervical spine, transport the patient on spine board, high degree of suspicion, place a neutral spine position, emergency two-piece cervical collar should be there, scoop style stretcher, and a spine board should be used. Once the patient reaches the emergency, primary and secondary survey as the ATLS protocol, imaging like X-rays, cervical spine epilateral, dorsal spine epilateral, lumbar spine epilateral. Steroid. This is debatable, but methylprednisolone bolus dose 30 milligram per kg, then infusion of 5.4 milligram per kg per hour. It is beneficial only if given within 8 hours of injury. After that, there is no use of methylprednisolone. It has rather side effects. Most commonly used agent is methylprednisolone in high doses. This is the algorithm for management of spinal injury. Primary survey, as a rule, airway, breathing, circulation. Secondary survey, examination of the spine and neurological examination. Radiological investigations, assess stability, if it is a stable injury or unstable injury. Stable injury, usually no neurological deficit, conservative management only. Rest and immobilization with the brace. If it is unstable injury, neurological deficit, then surgery is needed. The goal is early stabilization and rehabilitation. If it is incomplete injury, you have to decompress and stabilization is must. If it is complete injury, the role of decompression is debatable. Only the goal is early stabilization and rehabilitation. That is fixation of the spine. These are the braces we use. A is cervical collar, which is soft. Then Philadelphia collar at C. These Somai brace, Hello brace. Hello brace is used for cervical spine injury, upper cervical spine injury. Cervical spine injury starting from atlas, then axis. First cervical vertebra has no body, has two large lateral masses. 50% of total neck flexion and extension occurs at occiput and C1 junction. Then comes axis, second cervical vertebra. Its body is largest of the cervical vertebra. The transverse atlantoaxial ligament, cruciform ligament, provides primary support for the atlantoaxial joint. 50% of total neck rotation occurs at C1 C2 junction. Jefferson's fracture. It's a burst fracture of the ring of atlas C1 vertebra caused by axial compression force diving into a pond. Usually no neurological deficit. Can be 1, 2 or 4 part fractures. Diagnosis is by X-ray, especially open mouth view or CT scan. This is C2 vertebra odontoid fracture. Odontoid is a part of axis vertebra. Vascular supply arrives through the apex of the odontoid through its base and a watershed area in the neck. It's a high incidence of non-union. It's treated with a halo brace or surgery may be needed. It's a hangman fracture. Traumatic spondylolisthesis. Just like in lumbar vertebra, there is a spondylolisthesis because of breakage in pars interarticularis. Here also C2 vertebra gets fractured through the pars interarticularis. So neural arch of the axis of C2. Radiologically similar yet different from fractures due to judicial hanging caused bilateral axis pedicle fractures with complete disruption of the disc and ligamentous between C2 and C3. Most common cause now are MC and hyperextension of head on neck associated with vertebral artery cranial nerve injuries. Neurological injury is uncommon. Union almost always occurs. Comes to lower cervical spine, vertical compression, burst fracture, pure flexion, wedge fracture, wedge compression fracture, compression, flexion, teardrop fractures, anterior only, flexion, rotation, most common, subluxation or dislocation. It may be unilateral or bilateral. Jumped facets, we call it. We have to reduce it with Crutchfield. On increasing the gradual traction, it comes back with the maneuver of flexion and extension. Avulsion injury of C7 T1, clay Chauvel's fracture. So this is wedge compression fracture. Anterior vertebra is compressed. Pure flexion forces. This is burst fracture with the neurological deficit as the segment is gone into the vertebral canal. Retropulse fragment need to be pushed forward. This is teardrop fracture, flexion compression injury, clay Chauvel fracture. You can remember the names and the pattern of fracture only. It's avulsion injury. In lower cervical spine injury, more commonly associated with the spinal cord injury, increased motility rate, commonly present with neurological shock. True dislocations common as the facet joint are horizontal in orientation. Most common site for dislocation is C5, C6. Bilateral facet, more chances of neurological deficit, can be more easily reduced with closed traction than unilateral facet. This is whiplash injury. It is very common in females, hyperextension of head and neck and hyperflexion of head and neck. X-rays shows straightening of the spine because of muscle spasm. MRI may be normal. Improvement in 1 to 3 weeks with the cervical collar. Scivora we call when spinal cord injury is there without radiological abnormality. Scivora is a short form of this sentence. Spinal cord injury without radiological abnormality. X-ray is normal commonly in children. Usually incomplete spinal cord injury can be seen in older patients also with degenerative narrow spinal canal. They usually present with central cord syndrome. Thoracolumbar junction is most common site for injuries because of transitional zone. Most mobile segment is there. The ratio of spinal canal dimension to the spinal cord dimension is smallest is T2 to T10 region, dorsal spine, which makes the area prone to neurological injury after trauma. Middle column stability most important. Instability criteria defined by White and Punjabi. Minor injuries like articular process, transverse process, spinous process, and part interarticularis fractures. Major injuries like compression fracture, burst fracture, fracture dislocation, and seat belt injuries like chance fracture. So these are examples of few fractures. First slide A, which is showing the compression fracture where only superior end plate is broken, and last D is showing the dislocation of D11 over D12 with the sagittal CT reconstruction. Chance fracture described by chance, combined flexion and posterior distraction may cause the mid-lumbar spine to jackknife around an axis that is placed anterior to the vertebral column. This is seen mostly in the lap seat belt injuries where the body is thrown forward against the restraining strap. Neurological damage is uncommon, though the injury is by definition unstable. We need to fix, however, the fracture unites well. The tear passes transversely through the bone or the ligament structure or both. Hinge at intact anterior longitudinal ligament. increase in vertical height of the vertebra, and lateral view opening up the disc space posteriorly. This is just a torn vertebra, tear हो जाती है पूरी. So this was the presentation about spinal cord injuries. We tried to cover cervical, thoracic, and lumbar spinal injuries. Dorsal lumbar is most common, as you all know. Incomplete cord injury need to be addressed with the fixation and decompression. Conservative treatment for stable fractures with bracing and bed rest, whereas fixation surgical intervention is needed for unstable fractures. So with this we complete the session today. Anyone can ask for question in the chat box. I can read it.